Thank you. Today I'll talk about the nationwide outcomes and costs of laparoscopic and robotic versus open hepatectomies. I'm Chetan, Patel, and I have nothing to disclose. So readmission after surgical discharge is a costly endeavor for the entire healthcare system. After surgical discharge, it accounts for approximately 20% of the healthcare costs of the entire country. Readmission rates after hepatectomy have been reported anywhere from 9.7% to 15.5%, depending on the individual study. Previous studies have been limited to readmissions at single institution studies and hospitals participating in NISQIP. And as you can tell, this could miss a significant amount of readmissions of patients who are admitted to other facilities. The majority of previous studies report 30-day readmission rates. And there's been recent data that says that in hepatic surgery, 45 days is a better time interval to capture the majority of readmissions. Additionally, there's limited data on readmissions comparing laparoscopic and robotic hepatectomy versus open hepatectomy. So the purpose of our study was to determine readmission rate after hepatectomy to include the patients who were readmitted to other facilities, and also to compare outcomes and costs of laparoscopic and robotic versus open hepatectomies. This was a retrospective analysis. We queried the 2013-2014 nationwide readmission database for procedure and diagnosis codes. The procedure codes used was for lobectomy of the liver and partial hepatectomy. Additionally, we used these codes to identify patients who underwent laparoscopic or robotic approaches, as well as patients that required an anastomosis of the hepatic duct to the GI tract, and patients that required concomitant colon resections. Diagnosis codes were used to identify patients that had surgery for primary hepatic malignancy, secondary hepatic malignancy, gallbladder malignancy, and other pathologies of the liver. We excluded patients who were younger than 18 years of age, patients that had non-elective admissions, and any records with missing patient data or hospital data. The outcomes of interest were mortality during initial admission, mortality during initial admission or readmission, and non-elective admission within 45 days, as well as length of stay and cost. Chi-squared was used to compare our categorical variables. Continuous variables were reported as a mean with standard deviation and compared with ANOVA. Multivariate binary logistic regression was used to compare our outcomes of interest and formulate odds ratios. And SPSS was used to perform the analysis. After reviewing the data, we found that there were 10,870 patients that underwent hepatectomies in our database from 2013 to 2014. 93% of them were open, and the remainder were done either laparoscopic or robotic. Regarding the pathologies, we found that 80% of the patients had either secondary malignancy of the liver or other pathologies, and then about 20% were compromised of patients with primary hepatic malignancy and gallbladder pathology. Anastomosis of the hepatic duct to the GI tract was performed in 3.7% of the patients, and 11% of the patients had concomitant colon resections during hepatectomy. The overall mortality rate we found was about 3.1%, and the overall readmission rate within 45 days was 13.4%. Now, upon further evaluation, we found that 19.1% of those readmitted patients were actually admitted to other facilities, which could have been missed on other studies. In this graph, in this chart, we compare open, laparoscopic, and robotic. We did find that the mortality during the initial admission was lower in the robotic group compared to the other groups, and this value was statistically significant. As far as the readmission goes, the overall readmission rate was lower in the robotic group compared to laparoscopic and open. However, this was not statistically significant. We believe that if we did a subgroup analysis of these patients and compared robotic to laparoscopic alone or robotic to open alone, we find that this difference would be statistically significant. Here we demonstrate the odds ratios of, the other outcomes of interest. We found that the robotic group had a lower age compared to laparoscopic and open, and this value was statistically significant. The length of stay was significantly lower in the robotic group with a mean of 4.5 days after hepatectomy compared to laparoscopic and open. The Charleston Comorbidity Index was similar amongst the three groups. And what we found that was most interesting was that the overall total cost of the initial admission was lowest in the robotic group, which was the mean of about $24,900 compared to laparoscopic and open, which were both above $30,000. And this difference was statistically significant. And the cost of the readmissions was about the same amongst the groups. Upon further analysis, we found that the mortality and readmission rate was unchanged based on surgical approach alone. Regarding the pathologies, we found that the pathology itself did make a difference on the overall mortality or the odds of mortality for these patients, but not the readmission rate. Specifically, compared to primary hepatic malignancy alone, we found that secondary malignancy, gallbladder malignancy, and other pathologies had a lower odds of mortality. Age greater than 65 increased the odds of mortality, but not the readmission. And finally, an increase in the Charleston Comorbidity Index related to higher odds of mortality and readmission. Furthermore, anastomosis of the hepatic duct to the GI tract did correlate with higher odds of mortality and readmission, and these values were statistically significant. A colon resection, in addition to the hepatectomy, did not change the odds of mortality or readmission. Length of stay greater than or equal to 7 days did change both the mortality and the readmission rate, and these were statistically significant. And female patients correlated with the lower odds of mortality, but not readmission compared to their male counterparts. Next, we looked at what the reason for readmission in most of these patients were, and we did this looking at the all patient refined diagnosis-related groups upon readmission. And we found the majority of patients were readmitted for an infection of some sort, and then either hepatic coma or acute liver disorder post-hepatectomy, and lastly, intestinal obstruction. You can see the strength of the nationwide readmission database in that it captures patients that are admitted to other facilities, and we found that a readmission rate was 13.4%. The robotic approach we also found had the lowest length of stay, which did correlate into lower odds of readmission. And additionally, although the overall cost of surgery may be more, the total cost of the initial admission was significantly lower compared to laparoscopic and open groups. And lastly, the pathology, the age, Charleston Comorbidity Index, anastomosis of the hepatic duct to the GI tract, length of stay, and gender all affect the odds ratios of mortality and or readmission. Thank you.